Tēnā koutou katoa, ngā mihi nui kia koutou. Thank you, Annette, for inviting me to speak. I'm Moira Clunie, and I manage the Suicide Prevention Information New Zealand service at the Mental Health Foundation. Our role is to provide relevant evidence-based information to support everyone who has a role in suicide prevention, whether it's at a population level, working with communities, or supporting an individual. And my topic today relates to the international theme around World Suicide Prevention Day, Stigma as a Barrier to Suicide Prevention. I'm not going to talk about stigma around suicide itself, though it is real and is a challenge to all of us in our work, and particularly mahi to Lynn Russell for her korero about that this morning. Instead, I wanted to talk about suicide prevention for New Zealand's rainbow population. We know that sexual and gender minorities in New Zealand are at significantly higher risk of suicide compared to other New Zealanders, and that the main reason for this is social exclusion and discrimination. Essentially, the stigma related to having a non-normative identity is a major risk factor for suicidal behaviours. So I wanted to explore that idea for a bit, share some of the evidence, and talk about some of the work being done to address some of those issues. Definitions first. I'm using rainbow as an umbrella term to describe people who don't identify as heterosexual or don't fit standard sort of gender norms, and this covers a range of identities that span across three main categories. Firstly, sexual orientation other than heterosexual, so this could include lesbian, gay, bisexual, transgender, takatapui, queer. Second, diverse gender identity, which includes transgender, transsexual, takatapui, whakawahine, tangata iratane, whawhawhine, genderqueer, whakalaiti, akavaini, and many others. And thirdly, diversity of reproductive or sexual anatomy or intersex people. I'm also using sexual and gender minorities. You might also hear acronyms like LGBTI or shorthand like queer and trans. Language in this space is complex and shifting, reflecting that identity as complex. So to start with, a quick look at the evidence. Te Pou published a needs assessment report last year as part of the government's Suicide Prevention Research Fund, which found that GLBTI people have significantly higher lifetime risk for depression, anxiety, suicide and self-harm, substance use and eating disorders. It cites a range of studies. One example is the Christchurch Health and Development Study, which found in 2005 that predominantly homosexual men had over 5 times the rate of mental health problems compared with exclusively heterosexual men, including suicide attempts and suicidal ideation. So 28.6% of gay men reported attempting suicide, compared with 1.6% of straight men. 76% reported suicidal ideation, compared with about 11% of straight men. I'll pass really quickly over the Youth 2000 project because Matthias will talk about that in more detail shortly. But just briefly, the 2007 study found that high school students who said they were attracted to the same or to both sexes were 3 times as likely to report serious thoughts of suicide and 5 times as likely to report an actual suicide attempt in the past year compared to students who said they were attracted to the opposite sex. So 20% of same or both sex attracted students had said that they'd made a suicide attempt in the previous year. Very similar patterns are noted internationally. For example, the Stonewall Healthy Lives work in the UK looked at the health of gay, lesbian and bisexual people, found that young gay and bisexual men were 6 times more likely to have attempted suicide in the past year compared with straight men the same age. Australia's National LGBTI Health Alliance has reviewed this Australian evidence, noting, for example, that 36% of trans people and 24% of gay, lesbian and bisexual people currently meet the criteria for having a major depressive episode, compared with around 7% of the general population, so it's about 4 or 5 times as high. The Private Lives research into the health and wellbeing of GLBT Australians found overall poorer mental health compared with the general population, and also quite marked differences within the sample interviewed. So trans people reported the highest levels of psychological distress, followed by bisexual people, and then followed by same-sex attracted people. The Trans Nation study looked at more detail at issues for trans people in Australia and New Zealand, and its findings included that 1 in 4 respondents had had serious suicidal thoughts in the past 2 weeks. So, the research we do have paints a pretty consistent picture, and it's not a nice one, but I should say we don't have clear numbers on exactly how many rainbow individuals there are in New Zealand, or how many are depressed or anything like, or die by suicide or anything like that. Sexuality and gender diversity are not counted at population level within health services. They don't feature in coronial data related to suicide deaths. They're not recorded in the census and its related disability survey. They aren't routinely included as demographic markers in health, mental health, or suicide prevention research, with a few notable exceptions. There's a particular lack of data on Māori and Pacific populations, those from recent immigrant cultures, and on intersex people. And there are real difficulties in counting. Identity is complex, as I've mentioned, and it's sometimes private. It's not necessarily disclosed or known to friends or family members, and especially for young people, it doesn't necessarily have a name yet. The Lavender Island study, which looked at gay, lesbian, and bisexual identity in New Zealand, found that the average age where a young gay or bisexual man felt different was 11.2, whereas the average age that he came out to himself was 18.7. For women, the ages were 14.3 and 23. So there's a significant time period where someone might feel different, other people might treat them as though they're different, but they don't yet have a name for that difference. And it's really important also to say at this point that identity itself is not the cause of mental health problems. Rainbow individuals have the same potential to flourish as everyone else. There can be a real danger, I think, in conflating the experience of being a sexual or gender minority with suicide. We know that a disproportionate number of sexual and gender minorities go through a difficult time, but simply having these identities doesn't determine negative outcomes. The Youth 07 report that I mentioned earlier found that most same-sex attracted young people were happy or satisfied with their life. Most thought their school was okay and felt a part of their school community, and most had friends who they felt they could talk to about anything and who cared about them a lot. The Lavender Island study found that gay, lesbian, and bisexual identity can itself become a source of strength and well-being, especially in later life. So the negative outcomes I talked about are not due to identity themselves, but they're caused by discrimination and exclusion as key determinants of health. Researchers found that among the rainbow population, exposure to and fear of discrimination and isolation can directly impact on people's mental health, causing stress, psychological distress, and suicidality. This effect has been conceptualised as minority stress, that is, the idea of chronic stress related to being part of a stigmatised minority group. So common experiences that can contribute to minority stress among the rainbow population might be direct violence or bullying, homophobia or transphobia in families, communities and work settings, heterosexist discrimination, those sort of built-in assumptions in society and law that favour people who don't fit under the general rainbow umbrella, insults, threats and verbal abuse, higher rates of exposure to sexual assault, secrecy and shame associated with intersex conditions and the medical procedures that have been associated with those, internalised stigma or a lack of positive self-concept due to growing up in an environment that doesn't accept or validate an individual's identity, invisibility through heteronormative assumptions, for example within education, community or faith-based settings, or in services like primary health or mental health, and lack of access to safe, effective health and mental health services due to limited practitioner understanding. So just briefly, for example, the Youth 07 study found that the health and wellbeing of many same or both sex attracted students was negatively affected by their social environment. More than half had been hit or physically harmed by another person in the last 12 months. And of those that had been bullied, a third had been bullied, they said because they were gay or because people thought they were gay. And 1 in 5 continued to be afraid that someone would hurt or bother them at school. The Lavender Island study found that the effects of bullying can be lifelong and can include lower educational attainment, lower income, and lower levels of satisfaction with identity. And on the other side, very briefly reviewing the evidence, acceptance can be explicitly protective. So a 2011 Australian study found that supportive family responses to a young person coming out reduced the risk of suicide or self-harm behaviours. And various studies have found links between supportive schools and less risk. For example, in the States, having anti-discrimination policies in schools has been linked to better mental health outcomes. So how do we address this? I'm suggesting we need to prioritise inclusion and challenge discriminatory structures and attitudes. Social exclusion is a key determinant of mental health outcomes. Homophobia, transphobia, and other forms of discrimination are not usually problems with an individual. They're social problems and they need to be tackled and addressed at that level. The Te Pou Needs Assessment pointed to the need for mental health promotion at 4 levels for individuals, organisations, communities, and across the whole of society. So looking at those 4 in reverse, strengthening whole societies through interventions designed to counter stigma and discrimination and reduce inequalities. This includes legal and structural changes, but also public awareness campaigns to address stigma, homophobia, and transphobia. Beyond Blue in Australia ran an interesting social marketing campaign last year targeting homophobia and transphobia and asking people to consider these attitudes in comparison with discriminating against someone for being left-handed, something else that's just part of who you are. The Te Pou report identified a need for mental health promotion targeted towards the LGBTI population, as well as components within mainstream mental health promotion programs, such as Like Minds Like Mine and the National Depression Initiative, to destigmatise mental health issues within the LGBTI community. The second area of focus is strengthening communities to increase social cohesion, social participation and inclusion. Challenging discrimination at a community level is a really broad task. Initiatives include diversity education in schools, for example, the great work that Rainbow Youth does in this area locally. This kind of work challenges and removes discrimination in the environment around young people. The Te Pou report also talked about the importance of social acceptance and connection within LGBTI communities through social spaces and initiatives like Auckland Pride. The third area is around strengthening organisations to ensure environments are inclusive, safe and supportive. Within mental health services, for example, access to services and the competency of mental health services in supporting Rainbow clients are 2 of the key issues. In Auckland, the Let's Talk About Sex project has done good work in this area. The research led by Auckland DHB surveyed the experience of Rainbow mental health service users. They developed best practice guidelines and worked with affinity services to develop an organisational development program that includes auditing and staff training. Affinity are now delivering this training across other NGOs and mental health services across the Auckland DHB area. And the kinds of things they address are just basic things, like staff being able to ask about sexuality and gender identity in appropriate ways and being comfortable talking about those issues as they impact on mental health without further stigmatising. And for the organisation, ensuring a welcoming and inclusive space for LGBTI people through things like using inclusive language and ensuring that the questions on your forms are suitable, things like that. The 4th area from the Te Pou report was around strengthening individuals' self-esteem, self-efficacy, life and coping skills, relationships and social connections. And this is a role for everyone, really, for yourself, within your own family or whānau, and wherever you interact with someone professionally or personally. Social change can't be funded or legislated for. It comes from each of us examining our own practices, behaviours and attitudes. Finally, the Te Pou report also identifies the need for national and coordination and leadership. We don't have this yet, but I've been part of a group of organisations, researchers and individuals who work in the area of wellbeing, mental health and suicide prevention with Rainbow communities in New Zealand. Some of us organised a conference earlier this year on the topic, and we've been in conversations since then to identify ways to improve evidence, understanding and practice so that we can make a difference. So if you're interested in being part of this conversation, I invite you to get in touch with me. And I'll finish there. Thank you for your time.